Hey, everybody, it's Vicky with Dementia with Grace. How is everybody doing today? I hope that y'all are doing great. We have a special guest today, and y'all can see her right there on the screen. Her name is Dr. Brittany Lamb. We are so excited to have her. She has a specialty in emergency medicine, and she is a practicing physician in an emergency room, emergency department. It's named something all over the nation, but she has a specific interest in advanced directives. And that is something that I see in my group a lot, the group over on Facebook, the Dementia with Grace Caregiver Support Group. And we talk a lot about advanced directives, about how to set them up, about what they mean, about the ramifications of having one in place and the ramifications of not having one in place. And so I am very, very pleased to be able to make her acquaintance and then to introduce her to you. So, Dr. Lamb, if you would um, give us a little bit of background about yourself and how you found yourself on this journey.
Hi, everybody. Thanks so much for having me here, Vicky. I'm so happy to be part of the group and to try to give you guys helpful information and knowledge. So a little bit about me. I grew up in Florida, and then I always knew I wanted to be a doctor. I went to med school, didn't know what I wanted to do. Lots of reasons for why I went into ER, which is a whole separate conversation. But I did my training at UAB in Birmingham, Alabama. Loved that. And yeah, roll tide. And then
Okay.
and then I moved to Northern Virginia with my husband to be closer with my mom. And so I work in the ER now full time here, and I've been in attending now for almost 5 years. I've always had a passion for advocating for people when they cannot speak for themselves, especially when it comes to them being critically ill. I think it is incredibly important to talk to your family and friends and whoever will be making medical decisions for you so that they know what you do and do not want. And I think that that conversation needs to be had across the board with everybody. But with dementia, it makes it even more challenging because, people slowly lose the ability to speak for themselves and advocate for themselves. And you're being asked to do that for them. And if you don't have a medical background or medical knowledge, it can be really overwhelming trying to make decisions for them and trying to weigh out, where they are in their journey with dementia and how, quote unquote, aggressive you do or do not want to be and be with their treatment. So I feel like there's a big need for people to have more education and support in learning how to plan, and advanced directives are a huge part of that. But what I also want people to realize is that you also kind of need your own plan. So your own plan for how you will react to your specific loved one's medical complications of dementia, because those are known, and then also the complications of any other diseases they have.
I
So
think that's
that's
an excellent point. Excellent. Because I think when people think of advanced directives, they think of no pulse, no breathing, they're down. What has to happen now? What is going to happen now? And the run up to that is, a lot, there's a lot that happens at the end of life, which can be, it's not just the moment, it's the end of life. End of life in a dementia person is the whole entire stage. If you're staging stage 7, stage 6, 7, end stages. And there's a lot to think about there. And how you want the end, what do you want the end of your life to look like? Do you want a lot of intervention, or do you just want comfort care? So can you talk about a little bit of the types of advanced directives that can be put in place? The difference between, I think, the terminology we need to establish,
Mhm.
a DNR, DNI, a pulse, all of those EIEIOs,
Yeah.
that caregivers come into contact with, and they don't really understand the difference between all of that. And when does it, if you do a DNR is a do not resuscitate. If you put a DNR into place, when does it activate? Those kind of things. Can you talk on that?
Absolutely. Let me just rewind to something else that you said too about, end of life. There's a whole bunch of other things before you even get to end of life in the mid stages of dementia and even in the early stages of dementia that people can have medical complications like infections and
Yes.
falls and things like that. And I want people to create a plan for how they're going to deal with those things as well. So, but end of life is also obviously, a big part of this, and the advanced directives are more helpful in those situations. So, there's kind of two types, let's say like two groups of advanced directives, the ones that you can do ahead of time when you still have the ability to make decisions for yourself. So the most common one in that situation is going to be a living will. And typically those are drafted by an attorney. I have a bone to pick with living wills unless your attorney specifically, puts in caveats for when you have severe dementia and list out those symptoms that you consider severe dementia, and then this thing will activate. So a living will you put in place ahead of time, you're making your own decisions, putting them in writing, and usually a living will come into effect when you lose the ability to make your own medical decisions.
Okay, so question, teacher.
Yeah.
Can you specifically ask do most attorneys know the kind of language that needs to be included for a person with dementia, or do you need to seek out an attorney that is versed in writing the language that needs to represent the person with dementia? And does that exist? How would you Google that?
Yeah, what, Vicky, that's a really good question. I've seen some living wills that are, really great, and I've seen some that are just, really vague in general.
Yes.
I think the issue with so I think that if you can find an attorney that is versed in dementia, and knows what things, they maybe need to be put in there. But I also think that by consulting your doctor and setting down goals, or with working with me, and doing this ahead of time, you could, you could do that for yourself, but like you can't do that for your loved one with dementia. So that's the issue, because you almost have to forecast that you may have dementia and do this ahead of time, because a living will you're doing for yourself. And so it's another issue with living wills, because a lot of times people do them when they're like 50, 60 something years old,
right,
and they don't get updated when they develop a chronic disease like dementia or COPD or heart failure. So there's an issue with living wills. And they hardly ever make it to the hospital. So people won't bring
I see that too. I see that too as a practicing social worker when I was in a facility. When they came in, and one of the leading questions is, is there an advanced directive in place? Yeah, I think Mama did do a living will, but I don't know. Do you know where it is? Maybe it's in the safety deposit box. And even their doctor didn't have. I would ask the doctor, can y'all fax over a copy? They didn't have it. So yeah, so if your person, if you think now, if you're watching this and you think your person has executed some document, has memorialized their wishes in some written form, find it and put it in the binder. We talked with, I shared a video with Dr. Natalie the other day about having an emergency binder. And one of the places that she had said to have in the binder was an advanced directive part in there, where you kept an advanced directive, and you that notebook followed that person from the home to emergency care to the nursing home, to residential care, that kind of thing. So that's interesting.
Yeah. And you have to read it, and you have to know what it says. And then you have to know whether or not your loved one would still feel that way, because if you're their medical decision maker, you're speaking on their behalf, and you have to realize they may have written that when they were 60 years old and they didn't know they were going to have dementia. But most of the time a living will, like, to back up, most of the time a living will is going to go into effect when you lose the ability to make your own decisions, and when you have a terminal or end stage, like severe disease, and physicians think that you're dying. So that's a living will. And then the other advanced directives I think come more towards end of life are, and not necessarily a DNR, and I can speak more to that in a minute, but like the DNR, DNI is do not resuscitate is a DNR, do not intubate is a DNI. So a DNR form typically, almost all the time, only includes two things. It includes if your heart is to stop beating, you do not want to have CPR, right? And if you, are to have an issue with breathing, that you need to be put on a ventilator and there's nothing else we can do for you, we're not going to do that. So those are the only two things a DNR covers. So people have the common misconception that if they're a DNR, they're going to roll in and we're not going to do anything for them.
Right. Yes.
That is so far from the truth. I could not yell it more. I am not going to let your loved one languish if they have a DNR. I mean, there's so many other things that we can do. And that's a huge issue I see too. People think, oh, my loved one's a DNR. That means you're not going to, do all this stuff to them.
Give them oxygen, give them pain medicine, give them any intervention. They think that it's all or nothing. So
yeah, it's not. And
Yeah.
that's a huge, huge issue either way, because on the opposite, some people think that, oh, they're not going to, that means my loved one's comfort care and they're not going to do anything to them. They're just going to keep them comfortable. And that's not what it means. So it just pertains to those two things. And a DNI just is to intubation. So, do not intubate. That means that you could have CPR if you just have a do not intubate form. And I don't see those very often. I typically only see DNR order forms. They
Right.
usually go with both things. It's hard to, when someone loses their pulse, it's hard to decide you're just going to do CPR, but you're not going to intubate them. I mean, you can, but it doesn't make sense to us necessarily from a medical standpoint.
Right.
And
The
then,
other thing that I see a lot, and let me introduce you, and interrupt this, is when you want to withhold nutrition, hydration, nutrition, that withhold withdrawal is what it's called in Alabama. And I see that in dementia. That I didn't see that in other other comorbidities, but I would see that in dementia where they would get to the point where they were losing weight. And the family had to make that decision if it had not already been, memorialized in a document. So, can you discuss that and just quickly? Of course you can. I mean, it's such a nuanced discussion.
It is. It's very tough. It has to be individualized to the person, But yeah, it's unfortunately, end stage dementia. People die from just dementia, and your mind shuts down, your organs shut down, and part of that is that you don't want to eat or drink anymore. You lose that desire to. And trying to feed someone, with a feeding tube or even IV fluids, trying to get them to drink can be dangerous. It can make them choke and can make them aspirate, which is where food or fluid goes into your lungs. Then that can make them more uncomfortable from a breathing standpoint. But I mean that, to decide that, I feel like you need someone to look at your loved one and tell you, if they're very advanced, it can make sense and can be more along the lines of comfort care to not feed and not give hydration, because that is prolonging life. And so it depends on what their overall goals of care are. But you can, living wills sometimes do mention that. They often will mention that in living wills. So that is helpful, I think, to go back and look at that to see if it's written, because a lot of attorneys will put in things like feeding tubes and artificial nutrition. And then the pulse form, like you mentioned earlier, that's another one that does include typically that type of treatment. So yeah, I don't know if there's anything that you want to ask me about.
No, I think I just wanted to mention that because it's not one that I had thought of prior to this, but I was just, that one came to mind. Define for us a post, a POLST.
Yeah, so it's not every state has them, and I can't tell you off the top of my head which ones don't. But basically it's an order, and so each state in each place that has one can have a different language and acronym for what they use. But POLST is physician orders for life sustaining treatment. And then there's other ones like MOLST, which is medical orders for life sustaining treatment. And then sometimes you'll see post like physician or provider orders. So the whole theme of this is that it has to be written like a DNR. It has to be signed by a medical provider, and that would depend on your state. Whether a nurse practitioner or a PA could do this. Obviously, a doctor can do it for you, but it's an order form. So like a DNR, a pulse form is portable. So if you're at home, it counts. If you're at a memory center, if you're living in an assisted living, if you're in the hospital, it transfers across all fields, wherever you are, essentially. And it's supposed to be followed. It's an order. If the patient signs their own order, which a DNR, they could potentially sign their own DNR. A pulse form with dementia, they probably won't be signing. But if a patient signs their own form, it cannot be overturned. because it's that, that's saying that that person had the ability to make their own decision. They put it in writing, and you have to follow this. If you, as a healthcare decision maker for your loved one, decides to change those orders and you signed them, you can do that. But a post, to go a little bit more into that, it typically includes the code status as far as DNR goes. So whether or not you want CPR and intubation, then it just goes a little bit more in detail about what other treatments you would want. And it typically breaks things up into 3 categories. So DNR is do not resuscitate. And then it's like comfort care. So it's like, I just want, treatment and interventions that are aligned with providing comfort. I may not want transfer to the hospital, which is something that I think is a really big thing that we should think about. And then there's this middle ground between like, I want to be comfort care, and I want everything done, because you can put that on a pulse form. It's like, I want maximum medical treatment. And then there's this middle ground where, I don't want to be intubated and I don't want CPR, but I'm okay with other treatments, that could prolong my life. And that's an area that I think really needs to get fleshed out for each person, based on their medical history. So
I think the misconception among the caregivers that I serve is that it's just all or nothing. I mean, that it's just, if I sign this piece of paper as a healthcare proxy, maybe, they have and maybe they did have a conversation with their person, 10 years ago, 15 years ago. Sometimes it comes up when another person in the family passes away and they didn't like what they saw at the end of life for that person. And they say, never let me die like that. Never let me languish like that. And, but then things change, and you just need to update the conversation. I myself at 49 years old had a heart attack and had open heart surgery, and I had a living will in place. I mean, I'm a social worker. I mean, I discussed with my husband and my grown daughter, what I wanted we just reviewed it, and we talked about, what happens as I go under, the knife, basically, for surgery. And, what if there are complications, coming out of, intubation or something? I mean, so it's important to talk about. It's a difficult conversation to have. And, they were kind of like, la, 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 la. Like, we don't want to talk about your death.
I know what could happen. I need you to think about
And I'm like, we're not talking about my death. We're talking about the end of my life, which could include death, and it could include life that looks a little different. And I want to make sure that you understand how I want that to play out. So I think it's a nuanced conversation that grown adult people should be able to have, and it's important.
Yes, I agree. But I do recognize that, obviously, when you can't talk to your loved one about what they want anymore, you're having to make these decisions on your own sometimes, and reflecting on a conversation you had 10 years ago could be really challenging.
The other thing that I see that I wanted to address with you is the difference in family dynamics there. Because, I mean, especially in dementia, you could have had 2 different conversations with a person. Daughter A could have heard mother say, I never want to go into a nursing home. I never, just let me die at home, da 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 da. And the other daughter, heard, do, everything possible, I want all the medical care, everything. And so if there is, if the person, when they were, cognitively able, if they never designated a healthcare proxy, what happens? What happens in the hospital if mother is critically ill, vitals are dropping, and you've got both daughters standing in the waiting room? As a physician, what happens? What happens? I'm interested in that.
Yeah. So, I mean, obviously every situation is going to be different, but, I typically like to do the most conservative thing if we don't have family on board. So if families are not agreeing with each other, I'll give them my straight up medical opinion, and if their loved one is actively dying, or I think that being aggressive and putting them in the ICU and putting them on a, ventilator, or even not putting them on a ventilator, but just starting critical care interventions, treatments. If I think that that's, ultimately not going to benefit them, and they're not going to get out of that situation with the same quality of life, or potentially have a worse quality of life, which is typically what happens, I'll
Right.
be upfront with them. Like, I'll just tell them, I really don't think that you should, I really think that you should consider not doing this, but, you guys have to come to an agreement and decision right now. And then usually if they can't come up, usually people will come up with some sort of middle ground and what they're okay with. And then if there's fighting, if there's people being aggressive, I mean, you
Yes.
kind of have to default to the oldest sibling. And so
Yeah.
the oldest sibling is the one that gets to, make the decision. But I typically don't do that. And I hardly ever see situations like that. I mean,
Good.
especially with patients with dementia, it's, you know, I mean, I know it's so hard to watch your loved one like slowly lose who they are. And I feel like, obviously family dynamics can be very, very different.
Yes. Yes.
But mostly what I've seen is people being just very upset and not ready to let go.
Yes.
And I'm trying to help them not make a completely emotionally based decision, which
Yes. There you
may
go.
it may sound really harsh, but like, I'm able to look as an objective outsider and try to give you, the overall picture of what's going on with your loved one in the ER. And so I'm just pretty direct. I mean, it's also a time thing. I mean,
Yes.
I'm
Yes.
usually juggling 10, 12 patients at a time. So,
Yeah.
you know, I don't know. I mean, I don't know that that really is a great answer to your question, but
No, I think it's a realistic answer, and that's what I was looking for. I mean, because that's you can have a hard conversation early, or you can have a hard conversation late,
yeah.
and that is what I impress upon the people that I consult with. Usually I'm consulting about behaviors. That's the thrust of my practice is behavior management. But this does come up, and especially when somebody's trying to decide whether or not to put their person on hospice, and then that's when usually the advanced directives come up. And they say, well, it's just such a hard conversation to have with my brothers and sisters or my father. Maybe it's the spouse is the person with dementia, and the father's still alive, and the children are the main decision makers, but
Mhm.
the father has to be considered if he's cognitively intact. But it's a
Yeah.
hard conversation to have with your parents, and it's just but anyway, and they asked me sometimes, who would they listen to? And if you're standing in the emergency waiting room, who would they listen to? And I'm like,
Yeah.
from my understanding, it's the spouse, and then it's the children,
Yes.
and then it's the parents, if the parents
Yeah.
were still living of the person. So
Yeah. And the siblings, and yeah.
yeah,
But
it's
yeah,
yeah.
it's oldest.
There's a hierarchy there, of people.
Yeah.
Um, but it's a hard conversation, but it's much harder to have when your person is, their O2 sat is dropping, and you've got all these people saying, we need to know something.
Yeah. Absolutely.
So
I mean,
you
that's
choose your hard. That's the way it is in a lot of situations in dementia. You choose your hard. There
mm,
are no easy options a lot of times in dementia, and you just have to choose your hard. That's I
yeah,
just see that a lot on the journey.
that's why I just really feel like these making a plan and having that plan in place for yourself is peace of mind. It's going to decrease stress, decrease emotionally based decisions, and decrease like guilt and regret. Because
Yes.
I mean, I got to tell you, with COVID and having patients, because with the COVID surge, so I'm an ER doctor, 5 years out of residency. I worked a little bit. They asked us to come upstairs and work in like our intermediate care unit. So it's
Yeah.
not the ICU and it's not the floor. I cannot tell you how many patients I saw that had like very end stage, severe dementia, that were up there, just, and they were languishing because their families didn't understand what was happening. I mean, they weren't allowed in. We were like FaceTiming with them during the day,
Mm.
and then once they would see what we were doing and someone would actually talk to them, because I also put the burden on us as healthcare providers. We are not doing a good job at this. We are not helping people understand what this stuff means and what these interventions mean, like not just for right now, but for going forward, you know. So anyway, but like I've seen so many people suffer by not thinking about this stuff ahead of time. And
Yes.
that's why I want people to not just rely on advanced directives, but have their own personal plan for how they will make medical decisions, you
Yes.
know, for
Yes.
their loved one.
Well, I think that's the true nature of advanced directive. I mean,
Mm,
it is giving your advance directive. I think we just get so, we just, it's kind of a toss away term sometimes when if you really think about it, it is saying, okay, I am well, I'm alive and well. And this is what I want the end of my life to look like. I mean, I've been a social worker for 30 years now. So, I mean, I know that, I have maybe a callous view of it. I don't know, but and I'm medically ill myself and chronically ill, and so I know that I have a different view. But I think it's a hard, brave thing to take a look at. You know, death is as natural as birth, and we make a birth plan. And so I think that it's not necessarily exciting. But you make a birth plan to, this is what I want. This is how I want it to play out. And so I think it's equally important, to make a end of life death plan and how that would look like. You want to die with dignity. Have
mhm.
you heard of the 5 wishes?
Yeah,
Um,
I have. I mean, I haven't read it in a while.
yeah, yeah.
I
That's
can't.
interesting to me. I want to look at that again. A lady a social worker that works in hospice introduced me to that. And I've not seen one in practice. And I already have something, so I didn't, pull it up and, look at it. But it seemed a lot gentler, maybe. Maybe something that would be more accessible, maybe
Mhm.
as a first step into thinking about what you would have. Basically, it delineates, these are at the end of my life, this is what I wish it would look like. It's 5 wishes about who would be involved, what the end of life would look like, what I perceive dignity to be. All
Mhm,
of
mhm.
those, it's 5 things. But
Yeah,
anyway, you can just
that's
look it
great.
up at, I think, 5wishes.org, but just Google 5 wishes. But I think that
I'll look
is,
I'll look at it again. The
yeah.
Conversation Project is another
Okay.
good resource, to kind of get you to start thinking about how to bring this up to your loved one. I think that's a really good,
The
resource.
conversation resource
Conversation Project.
project.
Yeah, I think maybe we can put some of this stuff, like, at the bottom of this video,
Yeah.
maybe?
I'll put it in the description.
Yeah. There's
Yeah.
another, really interesting, uh, kind of directive, but it's not medical at all. I think it's really, really good, out of Scotland, talking about it's for people who are going into living into like assisted living or memory care, and talking about, what's my favorite weather, and like what kind of music do I like, and all this, like what calms me, like what kind of like scents or like textures. I don't know. It's very, very interesting. I
Yeah.
think would be a great tool for people if they're, having nerves about, potentially having their loved one not be in their home,
Right.
and communicating their wishes from like just a overall like caring, taking care of their body, and making them, I don't know, have good days kind of thing. So I'll send
Yeah.
you that link too.
Okay. And that
I
is addressed somewhat, in my grace, Dementia with Grace.
Whoops.
The G, no, no, no. I mean, I don't gatekeep anything, girl. All the resources we are well aware of. Try to share all of that. But the G in the Grace is gather important details, and the
Mhm.
form in my book, and then I have a separate book called The Story of a Life, and it talks about who I am, who I was, and then what I like still, the kind of music I like. Do I
Yeah.
like it quiet? Do I like it loud? Do I like to people watch, or do I like to be alone with my books?
Yeah. I love that. I
That
love
kind of thing. And so, you fill that out for your person can fill it out if they're early enough, or you can fill it out for them. But yes, anything like that is, there's a beautiful book called, Listening is an Act of Love. And it is written by, it's another conversation kind of book. It's National Story Corps.
Okay.
That is a United States based project where they are recording all of these stories
Okay.
from all of these people, and it's very interesting. Anyway, I'll put that down here
Yeah, I
too.
would love to read that. I've not heard of it.
Yeah,
I just
it's
think that I think people think that when patients roll into the ER that, we just look at them, as bodies, and that's not it's not true. I mean, it is a really hard job, but when I see someone has dementia that can't talk to me, I don't think about them like that. Like
yeah,
I always
yeah,
I always stop myself and say, this is somebody's dad, this is somebody's
yes,
grandfather.
yes,
This person, what did I sometimes will ask them, well, what did you do for work? Just to like try to understand like a
yes,
little bit about them.
yes,
It's a depersonalized environment, the ER. It's really easy to get like that. But I don't want you guys to think that all providers and nurses and doctors think like that, because it's not true.
right, right,
I
and
mean,
I see that.
there's bad eggs out there for sure, but
Absolutely,
um,
absolutely. And two, our United States healthcare system is fractured. Absolutely. And you don't have enough time to really, I see that as a patient. And I've talked to physicians about that as a patient to
yeah,
say, I'm more than, what is on this. I'm more than fall risk, seizure disorder, coronary artery disease. I'm also a grandmother and a best-selling author. And, this is what I wish to be on my armband, but
yeah,
they have 10 minutes, to
I
run in there and stabilize me. And I understand that because I am also a practicing medical professional. So I understand that, but it's so anyway, that's a whole entire different conversation
yeah,
that we
yeah,
don't have time for. Brittany, thank you so much for your time today. I know that you're about to go on a shift. And so I
yeah.
just I really appreciate your involvement on this side of medicine to tap in with the caregivers out there that are trying so hard to navigate this journey. Tell me just a little bit as we end about your idea for a course and how to better help in a more, a more structured way. Tell me a
Yeah.
little bit about that.
Yeah, yeah. So, I would just like to tell people too, like you can find me on Facebook. It's just my first name, last name. All my stuff is public, and so you can, follow me or add me as a friend.
I'll put
And
that link down here too, y'all.
yeah, I'm doing Facebook Live videos to try to give out some more information. And so if you'd like to watch some of that stuff, go for it. But the course, it's a developing idea that I have. I'm wanting to put it in place and gather people to go through it. But my ultimate idea is, helping people, especially towards, the beginning of their involvement with their loved one with dementia, creating a plan. So creating a plan for how they will speak on behalf of their loved one from, early on all the way through to their loved one's end of life, thinking about how they can adjust their medical decisions as someone's dementia gets worse, because there's things that come up that are not end of life, right? And you have to
Mhm.
decide, does this treatment, does getting a pacemaker make sense? Does having surgery when you hit your head and you have bleeding in your brain make sense? Are we going to keep treating urinary tract infections? At a certain
Yes.
point, maybe we're not going to. Like, there's just so many things that have to be thought about, and it kind of has to be tailored to your loved one. So my idea for the course is to create general knowledge for people with all the medical complications of dementia so they can learn about them. Then I want people to tell me the medical problems that their loved one has so I can create content on those things so they can learn
Yes.
about those complications. And then I'm going to give people access to me, through like a weekly Q&A group kind of phone call where they can ask me questions.
Right.
I can't like give specific medical advice to people,
Of
but I can
course.
answer general questions and kind of point them in like the right direction of
Right.
where to go.
Right.
So that's the idea.
I think it's wonderful. I think it's wonderful. So right now, jump on her group, jump on my group. If you're not already, this is going to be, this is YouTube. So obviously you have found us here. So subscribe down there. There's a button down there somewhere to subscribe. Hit the bell so that you're already always notified of when a new video drops. And then come on over and join the group, the Dementia with Grace Caregiver Support Group. Join Brittany's group. get in there so that you can know, when these new courses drop, when new videos drop, so that you are well informed. I know that you are on YouTube looking for information because you are a concerned caregiver who wants to be a well informed caregiver so that you can have your journey be just a little bit easier. Thank you for joining us. Thank you for joining us, Brittany. We appreciate your time. Dr. Lamb, I shouldn't be so informal. Thank you.
Oh,
Thank
it's
you.
fine. Whatever.
Thank you for joining us. And we will see you in the next video. And find us anywhere, everywhere. I'm Dementia with Grace. Y'all take care. Love y'all. Bye. Mwah.